I am Dr. Shailesh Kelkar. I am a consultant neurosurgeon working with KIMS-Kingsway Hospital, Nagpur, as a senior consultant neurosurgeon. And we are working in this central India for last almost 5-6 years with this hospital. So the topic for today, which I wanted to discuss with you all, is neurosurgical intervention, when and why. ये टॉपिक मैंने इसलिए चूज किया है क्योंकि देर आर मेनी मिसकंसेप्शंस अबाउट व्हाट इज द फ्रेमवर्क ऑफ न्यूरोसर्जिकल इंटरवेंशन and how we deal with patients which come to us. तो ये बेसिकली वी विल डील इन टू सेगमेंट्स. एक तो क्रेनियल वर्क होता है जो कि ब्रेन से रिलेटेड होता है, और दूसरा स्पाइनल वर्क होता है जो स्पाइन से रिलेटेड होता है. द वेरी फैक्ट कि न्यूरोसर्जरी में टाइमिंग इज वेरी इंपॉर्टेंट. इसका एक सिंपल अगर मैं उदाहरण दूं तो जैसे बच्चा पैदा होता है, तो बच्चा पैदा होने के बाद देर इज अ क्रूशियल टाइम इन विच द चाइल्ड हैज टू क्राई so that the child's lungs get opened up and the breathing starts and the oxygenation is taken up by the child. At the same time, वहाँ पे एक pediatrician रहता है, the anesthetist is there and they assist the child to do that if the child doesn't cry. And that is critical because if the child doesn't cry within a stipulated time, there can be insult to the brain and the oxygenation system fails. Similarly, in neurosurgery, you have brain or the cranial work. इसमें we can divide this into multiple sub specialties. उसमें trauma is a very important specialty, जहाँ की जब भी एक्सीडेंट होता है या कोई इंजरी होती है तो उसमें we say that it is critical because golden hour concept has come in for trauma and stroke. सो ट्रॉमा में इनिशियल ट्रीटमेंट जैसे हम सब जानते हैं कि जहाँ पे एक्सीडेंट होता है वहीं पे इनिशियल फर्स्ट एड ट्रीटमेंट दी जाती है, और उसमें ABC यानी एयरवे, ब्रीदिंग एंड सर्कुलेशन, दीज 3 थिंग्स आर टेकन केयर ऑफ. यानी कि रेस्पिरेशन ठीक चल रहा है कि नहीं, और सर्कुलेशन ठीक है कि नहीं, बीपी वगैरह ठीक है कि नहीं, कहीं ब्लीडिंग है कि नहीं, वो देखते हैं. वहाँ से फिर बेसिक कंसेप्ट, बेसिक मैनेजमेंट करके these patients are shifted to the hospital. और hospital shift होने के बाद within the first 1 hour these patients need to be investigated and re-examined so that we come to certain conclusion as to what is the most critical injury which the patient has, और according to that the priorities are set, और उसमें फिर we try to deal with those priorities. There can be associated chest trauma, abdominal trauma, but as far as cranial work is concerned, CT scan brain gives us a fair idea depending upon our clinical assessment कि इसमें कहीं ब्रेन में क्लॉट है कि नहीं, ब्रेन के सरफेस पे क्लॉट है, एक्स्ट्राड्यूरल हेमाटोमा, सबड्यूरल हेमाटोमा या इंट्रासेरेब्रल हेमाटोमा होता है, तो उसमें रैपिड जो है हमको इंटरवेंशन करने की जरूरत पड़ती है. तो एंड दैट अर्लियर द डन द न्यूरोलॉजिकल आउटकम आल्सो डिपेंड्स ऑन दैट. So इसीलिए हम उसको बोलते हैं कि इट्स अ गोल्डन आवर ड्यूरिंग विच ऑल दिस थिंग्स नीड टू हैपन. सो विदाउट वेस्टिंग टाइम in trauma patients, in brain cases, you need to handle those. Similarly, when there is a stroke patient, again that's a concept of golden hour, जहाँ की patient has a presentation with acute neurological symptoms like weakness हो गया, बोलने में प्रॉब्लम आ रहा है, या कोई होश में अनकॉन्शियसनेस आता है, ये सब चीजें होने से there is a suspicion that it could be related to sudden occlusion of some artery or sudden bleeding in the brain. So these patients, when they are shifted to the primary hospital or a tertiary hospital, a primary CT scan and an MRI done, and that shows that there is some problem. So intervention in terms of if required neurovascular intervention, or sometimes there is a surgical intervention which is required. So again, as said, the time frame is extremely important. Similarly, in other cold cases also, you have to intervene. As a neurosurgeon, it is important for us to make those decisions कि जब हम डील करते हैं, फॉर एग्जांपल ट्यूमर है, जैसा ब्रेन ट्यूमर है, ब्रेन ट्यूमर कैन प्रेजेंट विथ वेरियस सिम्टम्स, प्राइमरीली जैसे हेडेक होता है, वॉमिटिंग होता है, विजन में प्रॉब्लम्स आते हैं, कभी कभी वीकनेस आता है राइट साइड लेफ्ट साइड में. सो अगेन क्लिनिकल एग्जामिनेशन करके, बेसिक इन्वेस्टिगेशंस करके, इफ द डिसीजन इज मेड दैट इट इज कॉजिंग प्रेशर इफेक्ट, we say that in cranial work, the pressure effect is most important. And whenever there is a tumor, you will have associated edema or the swelling. And as that sets in, the problems can increase. So that's the critical time when you need to intervene. So basically, medical treatment is also initiated so that you can take care of the swelling, as well as you have to initiate with the surgical intervention. So surgical intervention may you operate and excise the tumor, and that gives us the primary treatment. Then this tumor tissue is sent for histopathology, and according to histopathology, whether it is a cancerous tumor or a non-cancerous tumor, उसके हिसाब से फिर आगे की ट्रीटमेंट तय होती है. अगर कैंसरस ट्यूमर निकलता है तो ऑब्वियसली दीज पेशेंट्स आर सेंट फॉर रेडियोथेरेपी और कीमोथेरेपी एज रिक्वायरमेंट एंड एज पर द डायग्नोसिस. तीसरा प्रॉब्लम जो हम बोलते हैं कि वैस्कुलर इन्वॉल्वमेंट, कभी कभी पेशेंट्स प्रेजेंट विथ एक्यूट ब्लीडिंग इन द ब्रेन और सराउंडिंग द ब्रेन, एंड उसमें कभी कभी ऑन इन्वेस्टिगेशन वी फाइंड that there is a balloon-like thing which is called as aneurism or AVM, arteriovenous malformation. And when these are diagnosed on CT angio or DSA, that is digital subtraction angiography, and that is diagnosed, the earlier the intervention, the better the results, provided the surgical intervention is indicated in those patients. So these aneurysms are taken up for surgical clipping, and the subarachnoid bleed which is there, it is followed up with serial CT scan and MRI, and accordingly you deal with those situations which are evolving day-to-day basis. Then there is a condition called hydrocephalus. Hydrocephalus में क्या होता है कि ब्रेन में पानी जमा हो जाता है. It can be congenital, that is from birth, or it can be obstructive hydrocephalus because of some tumor or some lesion in the brain in the pathway of the CSF circulation. प्राइमरीली उसमें होता यह है कि पानी जो जमा हो रहा है उसका प्रेशर बढ़ने लगता है, और वो प्रेशर बढ़ने से ब्रेन की फंक्शनिंग पे इफेक्ट आने लगता है. एंड दीज आल्सो पेशेंट्स कैन प्रेजेंट विथ हेडेक, वॉमिटिंग्स, देन वॉकिंग में डिफिकल्टी, ये सब चीजें उसमें होती है. And if the hydrocephalus is diagnosed, उसका ट्रीटमेंट क्या है? तो we bypass the fluid which is collected. So we put in a shunt for these patients, and there is also one endoscopic procedure which is called as ETV, that is endoscopic third ventriculostomy. ये भी procedure किया जा सकता है, provided there are certain indications which obviously the neurosurgeons decide when and which procedure to do. फिर there are patients with some facial pain, trigeminal neuralgia. Then there is a patient with some flickering of the face muscles, hemifacial spasm. These patients, again, we have to follow up, and primary treatment remains medical treatment, but 90-95% respond to medical treatment. But there will be 5 or 10 patients who are refractory to medical treatment. So उसमें हम इन्वेस्टिगेट करके सर्जिकल इंटरवेंशन in terms of microvascular surgery, that is called as microvascular decompression, where the nerve and the artery is separated and you put in a graft there, so that there is no conflict between the artery and the nerve. और ये करने से the pain can be taken care of to some extent, and the medicines or the medication requirement goes down over a period of time, and maybe sometimes these patients are off medication also. So, as I said, in cranial work, timing of intervention is decided as per requirement. So, in cranial work, what are essential urgent intervention which is required? That is, as a life-saving procedure, obviously, when you have an acute bleed because of trauma or stroke, there, if it is a life-saving, you have to intervene urgently. So the decisions need to be taken within minutes and hours. Then neurological deterioration, if the patient was conscious और वो धीरे धीरे करके ड्राउजी होता जा रहा है, सुस्त होता जा रहा है, तो इसका मतलब है देयर इज अ रेस्ड इंट्राक्रेनियल प्रेशर, देयर इज अ प्रेशर जो है ब्रेन के अंदर बिकॉज ऑफ स्वेलिंग और बिकॉज ऑफ फ्लूइड कलेक्शन और बिकॉज ऑफ द क्लॉट इटसेल्फ, इट मस्ट हैव बीन इंक्रीजिंग. तो उसमें हमको इंटरवीन करके उसका प्रेशर रिलीज करने के लिए या प्रेशर कंट्रोल करने के लिए सर्जिकली वी हैव टू इंटरवीन. Then there could be some indications for curative as well as palliative, but they are more of a cold cases where we need to intervene with these cranial cases. As I said, in neurosurgery, we also deal with spine. So spine is also very important area where we deal with this, and spine trauma is again an important area. Patients can have polytrauma, इसमें कि you can have all organs involved, the cranial trauma, spinal trauma, you can have chest trauma, abdominal trauma. इसमें the priority is to chest trauma and abdominal trauma, and there could be fractures associated with that. But spine trauma, if it is diagnosed and it presents with weakness in limbs, either both the limbs, which we call paraplegia, or all the four limbs we call quadriplegia. And if that is suspected in our clinical assessment, then X-rays are done, then MRI is done, which again shows what is the area of involvement, और उस area के हिसाब से then the treatment, if it is acute compression or the pressure over the spinal cord or the nerves, then intervention is suggested. Sometimes there is an instability, that is the spine is unstable, so sometimes intervention with in terms of instrumentation is done. So you have some instrumentation जिसमें कि rod, screw वगैरह fix करके plating करके उसको spine को support देना पड़ता है. So again, this is very important. So this also falls in our rule of golden hour, where we deal with the spinal trauma. Then you have patients of degenerative spine, that is commonly known as the spondylosis, cervical spondylosis, lumbar spondylosis. इसमें भी जब neurological deterioration हो, the primary symptoms, so you get neck pain, back pain radiating to the upper limb, lower limb. Then there can be paresthesias और जैसा झुंझुनी आती है बोलते हैं, उसके साथ numbness आता है. ये symptoms commonly आते हैं. उसके साथ अगर weakness आने लगे, say for example your grip is getting weak in the upper limb, or your foot, you are not able to wear your slippers on a regular basis, these are really signs which are worrying. So neurological deficit in terms of motor deficit, then that needs to be tackled urgently. Similarly, if you have patients with this spondylotic changes or slip disc or sciatica, as you may say in a common layman's term, if you have urinary involvement, urinary bladder involvement, जिसमें कि यूरिन का कंट्रोल नहीं रहता या तो यूरिन पास करने में तकलीफ होती है, तो this is again a red flag sign. That's an urgent area of interest, and it should be dealt by a neurosurgeon at the earliest possible, so that we can prevent the further deterioration or the damage which is being caused by the pressure over the nerves or the spinal cord. So these two things are very important. Similarly, in spine you can have tumors which are इंट्राड्यूरल एक्स्ट्राड्यूरल ट्यूमर्स, यानी कि जो स्पाइनल कॉर्ड के इर्द गिर्द जो एक झिल्ली होती है ड्यूरा, उसके अंदर हो सकता है या बाहर भी हो सकता है, बट उसका प्रेशर अगर स्पाइनल कॉर्ड पे हो या नर्व्स के ऊपर हो तो उसको हमको डील करना पड़ता है, और उसकी ट्रीटमेंट जो है वो सर्जिकल एक्सीजन होती है. अब उसमें फिर से कुछ कैंसरस ट्यूमर्स होते हैं, कुछ नॉन कैंसरस ट्यूमर्स होते हैं. तो अगर ये नॉन कैंसरस ट्यूमर्स पर्टिकुलरली जैसा श्वानोमा बोलते हैं या मेनिंजियोमा एक ट्यूमर होता है, अगर ये ट्यूमर डायग्नोस होता है तो इसकी इट इज क्यूरेबल. Once you excise the tumor, the patients do very well if you treat it in good time. So all in all, if I say that in brain or spine cases, if you intervene at the right time, you are likely to get better results. So I always say that you should be very active, or you should make the decisions in right time, so that the results which the patients and the patient's relatives expect can be more favorable. Obviously, neurological patients will have their own pitfalls, and there will be problems which are there, which need to be discussed mutually. और उसके बारे में प्रोग्नोस्टिकेशन जो हम बोलते हैं कि इसमें कैसा पेशेंट कैसा बिहेव करेगा या पेशेंट का आउटकम कैसा रहेगा, इट डिपेंड्स ऑन द प्राइमरी डिजीज इटसेल्फ, then the stage of the disease, and at what time you intervene. All these things matter in the outcome of the patients. Ultimately, we all are dealing with these patients, and the primary aim is to improve the quality of life of these patients. I think I have dealt with today's topic, that is neurosurgical intervention, when and why. Both the things I have dealt with in detail. I think if there are any questions from the viewers, I would be more than happy to answer these questions. So there is a question: how do you determine if a patient requires surgical intervention for a neurological condition? That's what I have said, that in intracranial या brain की surgery में particularly we say that if the intracranial pressure increases, उसके जो साइंस होते हैं, जो पेशेंट सुस्त होने लगता है, ड्राउजी होने लगता है, देयर विल बी वीकनेस ऑन वन साइड which is opposite to the side which is involved. ब्रेन में कैसा है कि if the right side of the brain is involved, it will give signs on the left side. So in those patients you have investigated and you have diagnosed the patient, and you have found that there is a clot or there is a tumor or there is something which is causing pressure, you need to deal with it, then intervention is required, and we will suggest those surgical intervention. In spine cases, again, as I said, there will be certain telltale signs on clinical examination which will say that there is a pressure over the nerves or the spinal cord. There you examine, then you investigate properly, and you diagnose this patient, and then surgical intervention is advised. You can have next question. What are the risks associated with neurosurgery? As I said, neurosurgery is a relatively high risk branch where the meticulousness, or you need to be very meticulous in the procedures. So the risk is there, and as we always say, whenever you are doing some neurosurgical procedure, the results are seen immediately after the surgery. So, but the risk has to be explained properly to the relatives as well as the patient, and the mutual understanding about the risk involved is very important, because there can be discrepancies in the understanding, and that can lead to some further issues which are that fall in the legal domain. It is always important to prognosticate in the right background of the disease process, the timing of the intervention, and the outcome which is expected in these patients. So risk associated is there. Every procedure has its different percentage of risk which are there, which need to be explained. Next question is, can I have neurosurgery if I have other health conditions? This is a very important question. Neurosurgery can be offered in most of the patients, but according to the health conditions, we have to change our plan of treatment. For example, if patient comes to us with medical issues, say suppose he has got hypertension, diabetes, some cardiac issues, then we will have to modulate our timing of intervention, that the patient's BP needs to be under control, the diabetes needs to be under control, because it affects the outcome in terms of infection control. Then if the patient is a cardiac patient and he is on any antiplatelet drugs, those antiplatelet drugs can interfere with our surgical procedure, that during surgery or post-operatively there can be rebleed and recollection in the operative site. So what usually we do is, these patients, we stop the antiplatelet drugs for 5 to 7 days, and then the patient can be taken up. Obviously, this is done with the help of the physician or the cardiologist who is treating the patient, and with their consent, then only we can take up this patient with an added risk in these patients. There can be patients of kidney failure. They have their own set of issues which need to be handled, and all these patients are dealt with. There will be patients where the neurological status is very bad. In those patients, we usually tend to be more conservative in our approach, and we don't suggest that these patients should undergo any surgical intervention, because as a surgeon, I would want these patients to be very clear that whether they are going to benefit by this procedure and intervention at that particular time or not. If the patient is going to get benefit, then that needs to be explained, and accordingly the patient needs to be taken up. If the patient is totally decompensated in terms of neurological status, we would not suggest any surgical intervention in those patients. Yeah. Next question is, what minimally invasive techniques are available for spine surgeries and how do they benefit patients? Minimally invasive techniques in spine surgeries has taken up by a storm, because this is an era of minimal invasive procedures. And in spine also we have minimal invasive procedures in terms of endoscopic surgery and microscopic surgery. These two are very commonly being practiced in our neurosurgical domain. And in spine particularly, if you see, then endoscopic procedures are, the indications are very clear. When you say that you are doing a minimally invasive technique, it has to fit into the specific indication. We should not overstretch those indications on our part. If, for example, if you have a slip disc, and if it is a young patient, slip disc, unilateral, that is the most ideal patient to undergo a minimal invasive surgery in terms of endoscopic excision or a microscopic or microdiscectomy. So minimal invasive was also defined as minimum required for that particular problem. So every surgery is a minimal invasive surgery, but in today's layman's term, minimal invasive or keyhole surgery becomes if you are dealing with a endoscopic procedure or a microscopic procedure for a single level procedure. And every procedure you have to reduce the area of surgical intervention so that the morbidity and the side effects of the procedure can be curtailed. Yeah. When is neurosurgery recommended for brain tumors? I think I have already answered this question in my talk, but brain tumors causing mass effect, pressure effect, or it is likely to cause mass effect, presenting with headache, vomitings, visual disturbances, weakness, neurological deficits in terms of motor weakness or sensory deficits, vision involvement, speech involvement, particularly on the left side, or memory issues. These are the patients who are advised surgery, and they should undergo surgery. Obviously, and we are also interested in the histopathology of these lesions, because the tumors can be benign and malignant. Intracranial और intraparenchymal intrinsic tumors जो कि ब्रेन के अंदर होते हैं, वो ब्रेन के अंदर रहने वाले ट्यूमर्स मोस्टली मैलिग्नेंट होने के चांसेस ज्यादा रहते हैं. जो सतह पे रहने वाले ट्यूमर्स जो कि श्वानोमा मेनिंजियोमा जो ट्यूमर्स हैं, दे आर likely to be benign tumors, so the outcome is better. There are patients with infection also, so these patients are dealt with differently. There's one more question: can neurosurgery treat chronic pain or nerve disorders like trigeminal neuralgia? Yeah, I already mentioned that in my talk, that trigeminal neuralgia primarily 90-95% patients would be treated by medical treatment, and they have episodes of pain जिसमें कि दर्द जो होता है एक तरफ आता है एक साइड में, एंड वो पर्टिकुलर फिफ्थ नर्व जो कि ट्राइजेमिनल नर्व बोलते हैं उसमें अगर ये तकलीफ हो तो उसके कारण आता है। और ये पर्टिकुलरली कॉमनली उसके ऊपर नस के ऊपर नस चढ़ना बोलते हैं, जैसे वो जैसे वास्कुलर अगर लूप उसके ऊपर चढ़ जाए तो उसकी वजह से ये ट्रिगर होता है और वो वहां से कंटिन्यूअस वो ट्रिगर ये फायर करता है और वो पेन पेशेंट को बहुत तकलीफ दे रहता है। इट कैन ऑल्सो कॉज सुसाइडल टेंडेंसीज इन दीज पेशेंट्स। लेकिन अगर मेडिकल ट्रीटमेंट फेल हो जाए तो देन देयर आर 2-3 modalities which are used for this. One is surgical, obviously, in which if you are able to demonstrate on an MRI that there is a causative factor, that is a vessel का अगर लूप उसके ऊपर दिखता है कि नर्व को क्रॉस कर रहा है, उसके ऊपर प्रेशर दे रहा है और वहां पे कोई ट्यूमर कभी कभी डायग्नोस हो जाता है, मेनिंजियोमा वहां पे होगा या कोई दूसरा ट्यूमर वहां पे प्रेशर दे रहा है, तो सर्जिकल इंटरवेन करके वो ट्यूमर को निकालना या तो वेसल और नर्व के बीच में टेफ्लॉन ग्राफ्ट बोलते हैं, जैसे इंसुलेटर्स होते हैं, जैसे इलेक्ट्रिक वायर में आप जैसे इंसुलेट करते हैं वायर को, वैसे ही नर्व को इंसुलेट करने के लिए टेफ्लॉन ग्राफ्ट यूज होते हैं एंड दे आर पुट अराउंड द नर्व or then the vessel and the nerve you can create this graft there and place this graft and the conflict can be taken care of. इसमें trigeminal neuralgia में intervention के results are very good and they will reduce the medications which are required to a larger extent. इसमें कभी कभी दे पेशेंट्स 4-5 टाइप के ड्रग्स के ऊपर रहते हैं, उसमें से वो मोस्टली 1 या 2 ड्रग पे आ जाते हैं और ओवर अ पीरियड ऑफ टाइम वो उसकी फ्रीक्वेंसी भी कम हो जाती है। What is stereotactic radiosurgery and how is it different from traditional surgery? Stereotactic radiosurgery, if I am not wrong, it is stereotactic surgery. Radiosurgery is a different, totally, gamma knife is a totally different modality which falls under our and radiotherapist domain. So if I talk about stereotactic surgery, it is basically to have a diagnostic surgery, that is in layman's term FNAC जो बोलते हैं हम, वैसा एक प्रोसीजर है जिसमें स्टीरियोटैक्टिक फ्रेम होती है, उसमें से आप टिश्यू ट्यूमर तक पहुंच सकते हैं और वहां से छोटा टुकड़ा निकाल के उसका डायग्नोसिस कर सकते हैं। स्टीरियोटैक्टिक रेडियो सर्जरी या स्टीरियोटैक्टिक सर्जरी में आप ट्यूमर एक्सरसाइज कंप्लीटली नहीं कर सकते, जबकि ट्रेडिशनल सर्जरी जो है न्यूरोसर्जरी में आप ट्यूमर एक्सीजन कंप्लीट करने के लिए आप इसमें आप यू कैन प्लान द सर्जरी एंड यू कैन एक्सरसाइज द ट्यूमर। सो एक्सीजनल बायोप्सी जो हम बोलते हैं, तो पूरा ट्यूमर एक्सरसाइज करके हम उसको भेजने की कोशिश करते हैं, बट इंट्रा ऑपरेटिवली एज अ न्यूरोसर्जन हमको कभी कभी डिसीजन लेना पड़ता है कि ये ट्यूमर अगर कोई मेजर नर्व या आर्टरी के आसपास हो जहाँ पे ऑन टेबल रिस्क बहुत ज्यादा हो पेशेंट को इन टर्म्स ऑफ लाइफ एज वेल एज इन टर्म्स ऑफ न्यूरोलॉजिकल आउटकम, तो सब टोटल एक्सीजन इज ऑल्सो डन and it is well accepted that subtotal excision with saving the patient's neurological status as well as saving his life is more important in terms of the outcome. So ये दोनों में फर्क जो है स्टीरियोटैक्टिक सर्जरी और ट्रेडिशनल सर्जरी में ये फर्क है। One more question is, what precautions should patients take before and after undergoing neurosurgical intervention? In terms of precautions, neurosurgical intervention जब हम करते हैं तो उसके पहले ऑब्वियसली प्रिकॉशंस आर इन टर्म्स ऑफ मेडिकल मैनेजमेंट, जिसमें कि इंस्ट्रक्शंस आर गिवन टू इन्वेस्टिगेट द पेशेंट एंड पोस्ट ऑपरेटिवली जब सर्जरी होने के बाद मेडिकल मैनेजमेंट में देयर कैन बी सर्टेन इंस्ट्रक्शंस व्हिच आर गिवन पर्टिकुलरली इन टर्म्स ऑफ मैनेजिंग द वुंड। तो जो जख्म होता है उसको हील होने को रफली 8 to 10 डेज लगते हैं, तब तक दैट वुंड नीड्स टू बी टेकन केयर ऑफ। एक्चुअली ड्रेसिंग होती है तो उस पर हैंडलिंग नहीं होना चाहिए। अगर ड्रेन इंट्राऑपरेटिव डाला हुआ होता है तो वो सेकंड डे ड्रेन निकल जाता है, और उसके बाद में जो ड्रेसिंग है वो मोस्टली 10th डे को स्टिचेस निकलते हैं, तो पेशेंट इज अगेन आस्क्ड टू फॉलो अप एंड दो स्टिचेस आर रिमूव्ड ऑन द 10th day. So that is how we manage these wounds particularly, and according to our instructions, the patients के investigations की अगर जरूरत हो तो investigations कराए जाते हैं, CT scan MRI की जरूरत है तो वो कराए जाते हैं। Precautions अगर neurological deficits हैं already patient को, जैसे कि hemiparesis है, प्लीजिया है, एक साइड में हाथ पैर में कमजोरी है, अगर तो ऐसे पेशेंट्स को असिस्टेंस की जरूरत होती है, तो ऑब्वियसली नर्सिंग केयर बिकम्स अ क्रिटिकल इशू। और नर्सिंग इन टर्म्स ऑफ नर्सिंग फिर उनको कैसे हैंडल करना, फिजियोथेरेपी में कैसे हैंडल करना, उनको वॉकिंग के लिए क्या क्या सुविधाएं प्रोवाइड करना है, वॉकिंग में वॉकर्स हो गए या स्टिक हो गया, वो कैसे यूज करना वो बताया जाता है। जो पेशेंट बेड रिडन है उनके लिए भी वेरी इंपॉर्टेंट दैट नर्सिंग केयर इज एक्सट्रीमली इंपॉर्टेंट टू प्रिवेंट सेकेंडरी इश्यूज। पर्टिकुलरली पेशेंट नीड्स टू बी मोबिलाइज्ड so that nursing care has to be very good in these bedridden patients particularly, क्योंकि अगर पोजीशन चेंज नहीं करेंगे तो आपके प्रेशर सोर्स हो जाते हैं, बेड सोर्स हो जाते हैं। अगर पेशेंट इज ऑन कैथेटर देन द कैथेटर केयर बिकम्स इम्पोर्टेंट। There will be some patients who are put on tracheostomy, that is a tube which is kept in the neck area for breathing. The tracheostomy care, suctioning of the airway passages and oral suctioning is also important. These are the precautions which are advised as per the condition of the patient. Is neurosurgery effective for treating movement disorders like Parkinson's disease? Neurosurgery is effective. I say that you have a role for DBS, that is, which is DBS is deep brain stimulation. That's a procedure which is being done, and particular areas brain में जो होते हैं globus pallidus और पुटामेन के पास में, वहाँ पे जाके lesions create किए जाते हैं so that that arc is interfered with. And Parkinson's के patients जो again I said मेडिकल ट्रीटमेंट पे ही मोस्टली होते हैं, बट जब पार्किंसंस के सिम्टम्स बहुत ज़्यादा एग्रेवेट हो जाते हैं जो कि मेडिकली मैनेज नहीं हो रहे, तो उसमें आपको दिस इज वन मोडालिटी which can help these patients to somehow help them to reduce the frequency and the intensity of the symptoms. And medical management के साथ it is a, I would say it is a supplementary treatment for these. And DBS is being practiced at some centers, and the results are reasonable, I would say. It makes the patient more comfortable. It's not curative. It has to be very clear in our mind. So उसी हिसाब से इसकी तरफ देखना चाहिए। Next question है, how do neurosurgeons decide between traditional surgery and newer techniques like robotic or endoscopic surgery? There are two aspects to that. One is your level of training, which is important, and traditional surgery is where you start with, and with your seniority as well as your area of interest, you learn those techniques of endoscopic surgery or a robotic surgery. Robotic surgery is not being practiced in neurosurgery. There's a misconception. It is more of a navigation surgery, navigation assisted surgery, I would say. And navigation assisted surgery has also got its own benefits and pitfalls, which I think most of the well-trained neurosurgeons are aware of. Navigation, particularly in spine, yes, navigation has got a role, particularly while instrumentation. जब आप you want to put in screws or you want to delineate exactly what location you are in, so उसमें spine में बहुत उसका रोल है. वैसे ही cranial work में जो रोल है आपका navigation का, वो particularly skull base में it has got a role to play in navigation, but primary intracranial work there are issues because the brain shifts when you are operating, और वो उसकी वजह से navigation doesn't work. Endoscopic surgery has particular indications like intraventricular lesions जब होते हैं, या their ventricles जो ब्रेन के अंदर पानी की थैली होती है उसको लग के अगर कोई लीजन है तो उसमें एंडोस्कोप इंट्रोड्यूस करके हम उसको ट्रीट कर सकते हैं. उसमें एंडोस्कोपिक थर्ड वेंट्रिकुलरस्टोमी, जैसे मैंने बताया कि हाइड्रोसेफलस जिसमें पानी जमा हो जाता है, तो उसमें थर्ड वेंट्रिकल में आप एंडोस्कोप डाल के you can open up the third ventricle and it gives us the bypass for that fluid which has got collected. स्पाइन में भी एंडोस्कोपिक वर्क जो होता है वो बताया कि देयर आर स्पेसिफिक इंडिकेशंस और उसके हिसाब से वो किया जाता है. आजकल मिनिमल एक्सेस इंस्ट्रूमेंटेशन भी हो रहा है, बट देयर आर वेरी क्लियर कट इंडिकेशंस व्हिच ऑन पार्ट ऑफ अ न्यूरोसर्जन वी शुड बी वेरी cautious about doing these surgeries, because there are certain benefits of endoscopic surgery, but at the same time there will be benefits of traditional surgery also. So it needs to be balanced properly, and then the treatment plan should be offered to the patient. What are the non-surgical treatment options for brain aneurysm? ब्रेन एन्यूरिज्म जैसे कि जब ब्रेन में सप्लाई करने वाली आर्टरी जो होती है उसमें अगर बलून जैसा आता है, और वो अगर बलून इट इज प्रेजेंट इन 1% ऑफ द पॉपुलेशन, and out of that only 1% would present with some symptoms. So it is extremely rare issue, but इसमें non-surgical treatment means endovascular intervention होता है इसमें, जिसमें कि आप वहां जाके उसमें coils डाल के उसको block कर सकते हैं. तो this is one treatment modality which is being practiced, but in that you don't deal with the subarachnoid blood, या जो blood फैल चुका है वो endoscopically या न्यूरो vascular treatment से आप उसको डील नहीं कर सकते. So you will have neurosurgical backup which is required to deal with these patients, and these patients are followed up, and then accordingly कभी-कभी you have delayed infarcts because of spasm. The artery जो होती है वो सिकुड़ जाती है कभी-कभी थर्ड फोर्थ डे को, और उसके कारण इन्फार्क्ट्स हो जाते हैं, ब्रेन का ब्लड सप्लाई कम हो जाता है, बंद हो जाता है. तो सर्जिकल इंटरवेंशन करके हमको उसमें स्पेस क्रिएट करना या डिकम्प्रेसिव सर्जरीज करनी पड़ती है. सो दैट इज नॉट इन द डोमेन ऑफ एंडोवास्कुलर सर्जन्स, एंडोवास्कुलर न्यूरो इंटरवेंशन रेडियोलॉजिस्ट डोमेन. So neurosurgeons have got a big role to play in these patients, and there are definitive or curative treatment in terms may you have a clipping of these aneurysms. What was the most complex surgery you performed that you remember, and what was your experience? This is there are, to be honest, in last 25-30 years of my practice, there are so many complex surgeries which I would have performed. But in the initial days, I remember that I operated for almost 15 hours continuously for a brain tumor, which was there, a basifrontal meningioma, which was extensive in a young girl. And we had to really struggle to get it out. we could excise it completely. But unfortunate part was the patient came to us with a vision had already compromised. We could excise the tumor completely. It took almost 14-15 hours for doing that. And at that time, we did not have the gadgets which are available to us now. CUSA is a one gadget which is used for intraoperative aspirating the tumor, which breaks down the tumor and aspirates the tumor. So that makes the life of a neurosurgeon very easy. So initial part of my practice that was not available to us, and we had to manually excise the tumor completely. So it took a lot of time and patience. So these tumors, every now and then, they tend to really put you in a position, and they will test your patience and your skills. And in neurosurgery, no surgery should be taken lightly. Every small and big surgery can be having the same implications as far as the outcome is concerned. So you should always be alert when you are treating with these patients. That is what I myself feel, and then whenever I talk to any of the junior neurosurgeons and we discuss, we always say that no surgery has to be taken lightly. We always say that in neurosurgery, if you get a patient of hydrocephalus and you put in one shunt, these patients tend to come again and again because of some or the other complications. It's a high risk procedure. So though it is a very easy procedure, but it is a very high risk procedure. So these shunts get infected, sometimes they get blocked, sometimes when you have put in a shunt when the child has come in the initial phase of the life, and then the shunt tube gets shortened, then you have to revise the shunts. They keep on coming to you again and again and test you and your experience. What are the options for one with both lumbar and cervical radiculopathy symptoms? Actually, many times हमारे practice में we see that you will have patients of cervical and lumbar compression at the same time. So cervical lumbar compression, if dealt with, many times we do advise these patients can undergo surgical intervention in the same sitting, because the hospital stay, their medication remains the same. It's an additional procedure which usually most of the patients will tolerate well. And the rehabilitation process also for one procedure is as good as to have it for two procedures. So I have operated many patients having lumbar as well as cervical compressive radiculopathy or myeloradiculopathy in the same sitting. Sometimes you can operate it from the back side, and if cervical laminectomy, lumbar laminectomy, then these two procedures are done. Sometimes there are many approaches. You have to actually plan. अगर ये procedure एक बैक से कर रहे हैं और दूसरा एंटीरियरली या सामने से कर रहे हैं, तो फिर then the patient needs to be shifted in the operation theater, and then you have to operate on the cervical spine from the front. There are many procedures which are being done thoracic. Transthoracic surgeries are also a part of our armamentarium, जिसमें कि चेस्ट ओपन करके थोरैकोटॉमी बोलते हैं उसको, तो उसमें या ट्रांस एब्डोमिनल सर्जरीज जिसमें कि ट्यूमर या जिसमें प्रॉब्लम सामने वर्टिब्रल बॉडी में है, तो उसमें जाके ऑपरेट किया जा सकता है. और ये these procedures can be done in combination also if required. And the patients have to be explained obviously, because the operating time जो है वो बढ़ जाता है, और उसके issues जो भी होंगे वो ठीक से समझा के अगर patient is willing to take that risk, then obviously we need to give that chance. So thank you very much for having attended this live program, and I hope I have tried to give an insight into the role of neurosurgeon, neurosurgical intervention, what time and why and how. So I hope it's an useful information for you. Thank you so much.